I want you to think back to the very first test you ever took in your entire life. You definitely didn't study for it. And, well, you didn't even know it was happening.
Right, because it happened within literally 60 seconds of you being born.
Exactly. And it was graded on this really rigid scale of 0 to 10.
It is basically the ultimate pop quiz.
Yeah.
And, arguably it's the most high-stakes assessment any of us will ever face, just given what those numbers dictate right after birth.
Yeah. So today we're taking a deep dive into the APGAR score. And whether you're like a nursing student prepping for an exam or just an insanely curious learner, this is going to be your definitive guide to how a newborn is scored in those first 60 seconds. It's such a fascinating topic, too.
It really is. Our mission today is to unpack the surprising, honestly kind of accidental origin of this universal checklist, break down what the 5 criteria actually measure biologically, and, explore how a simple 0 to 10 scale from the 1950s became the center of these massive modern controversies. Yeah, because the APGAR score is almost always taught as this fixed, timeless pillar of medicine. Like you learn the textbook definition, which is a rapid clinical checklist used to summarize a newborn's condition.
Right.
But its identity has shifted so dramatically over the years. I mean, it went from being this marginalized data collection tool to a literal life-saving trigger, and then eventually to a heavily distorted piece of legal evidence.
Which is wild. But before we get into how the test works today, we really need to understand the environment that made it so desperately necessary in the first place. Because if we transport ourselves back to a delivery room in the early 1950s, we are not looking at the hyper-specialized, highly monitored room we expect today.
Not at all. The historical context is, frankly, a bit jarring. Back in the 50s, essentially all clinical attention was trained entirely on the laboring mother.
Just the mother.
Yeah, the obstetrician's job was to deliver the baby and just ensure the mother survived the process, which, was still remarkably dangerous at the time.
Wow, okay.
So once the baby emerged, if it looked pale or limp, or maybe was barely breathing, the medical team would often just set the newborn aside, like sometimes literally on a side table covered with a towel.
Wait, just left on a table? That sounds completely unthinkable now. I mean, you'd expect immediate alarms and a whole rush of pediatricians.
Right, but the paradigm was entirely maternal-focused. And compounding that danger was this complete lack of shared vocabulary for a baby in distress. If a newborn wasn't doing well, a doctor or nurse might just, jot down a vague impression on the chart.
I like what?
Things like poor color, breathing poorly, or literally just looked bad.
Looked bad. That is terrifyingly unscientific. I mean, that tells the next nurse coming on shift absolutely nothing about the baby's actual physiological state.
Exactly. It varied wildly depending on who happened to be looking at the baby, and frequently it wasn't even recorded at all. There was no standardized scale, no objective way to communicate urgency.
And that chaotic, super subjective environment is where we meet our innovator, Dr. Virginia APGAR. She is an absolute legend in medical history.
Oh, absolutely. She was an anesthesiologist at Columbia University's College of Physicians and Surgeons. And in 1949, she became the first woman appointed as a full professor there.
Which, in the mid-20th century medical establishment, is just a monumental hurdle to clear.
Yeah, and her background adds this really fascinating layer to it. She had actually trained as a surgeon in the 1930s, but she was actively steered away from surgery, which was the prestigious male-dominated field, toward the newer, lower-status specialty of anesthesiology.
Her mentor essentially told her that a female surgeon would never find financial backing or patient trust, right?
Exactly. So she took that redirection and just poured her brilliance into anesthesiology. She almost single-handedly built the anesthesia division at Columbia's Sloan Hospital for Women.
Which put her directly in the delivery room for thousands upon thousands of births.
Right. And her entire career as an anesthesiologist was built on vigilance. I mean, when you're keeping someone under anesthesia, your whole job is to watch for the most subtle, minute warning signs of physiological distress.
You're obsessively monitoring breathing, color, pulse.
Yes. So when she saw these pale, limp babies being ignored on side tables, her instinct was to apply that exact same rigorous observational discipline to the very first seconds of life outside the womb.
But according to our sources, she didn't actually set out to invent a global triage tool, right? Like, The most famous newborn assessment in the world started out as a basic data collection spreadsheet for a research paper.
Yeah, she was just trying to answer a really specific scientific question. She wanted to know, did the anesthesia given to a laboring mother affect how well her baby handled the transition to life?
Okay, so to study that, she needed to standardize her observations.
Exactly. She needed a consistent way to grade the babies so she could compare the data across hundreds of deliveries.
Wait, so you're telling me the most famous newborn triage tool in the world wasn't even meant to be a triage tool? It was just a spreadsheet. That's like a scientist accidentally inventing the modern fire alarm while they were just trying to measure room temperature for like a thermodynamics paper.
That is a great comparison. She was just doing her research. And there's this fantastic origin story that circulates in nursing schools about how she actually finalized the criteria.
Oh, the cafeteria legend?
Yes. The legend goes that a medical student asked Dr. APGAR over breakfast in the hospital cafeteria how one might systematically evaluate a newborn. And she supposedly said, "That's easy. You just take 5 signs and score them," and sketch the whole system out on a scrap of paper right there over her coffee.
Which is amazing. I mean, we don't know for certain if it happened exactly that way, but she did formally publish this system in 1953. And it caught on so rapidly because it solved a massive, complex problem for $0.
Right. It required no specialized equipment. It took under a minute, and it gave every nurse, midwife, and doctor in the room the exact same objective number to shout out.
So she realizes observation is key, but human beings are incredibly subjective. How did she actually force doctors to measure a baby objectively using just their eyes and hands? Let's break down the mechanics of the checklist.
Well, we should probably clear up a massive misconception first.
Oh, right. Because if you ask anyone who works in obstetrics what APGAR stands for, they'll probably list off appearance, pulse, grimace, activity, and respiration. APGAR. Except she didn't name it that.
No, she didn't. The acronym is a total myth, or more accurately, it's a backronym. Virginia APGAR published the original scale under her own surname, purely by coincidence.
A full decade later, right? Around 1963.
Yeah, about 10 years later, a pediatrician named Dr. Joseph Butterfield realized that her name perfectly aligned with the 5 vital signs of birth. So he coined the APGAR mnemonic as a teaching device for his medical students, just to help them memorize the criteria.
That is an unbelievable stroke of historical luck for her legacy. I mean, to have your name literally spell out your invention.
It really is.
So let's look at those 5 vital signs. Each of the 5 criteria gets a score of 0, 1, or 2. And you add them up at the end for a total score out of 10. Let's start with the A in the mnemonic appearance. This assesses skin color, right?
Yes, skin color. Because it's a visual proxy for how well oxygenated blood is reaching the extremities. A score of 0 means the baby is pale or blue all over.
Okay, and 1.
1 point is given if the body is pink, but the hands and feet are still blue. The medical term for that is aquacyanosis. And then 2 points if the baby is entirely pink from head to toe.
So a baby having blue hands, but a pink body, it's kind of like turning on the central heating in a really large house. The core, like the living room where the thermostat is, gets warm super fast, but the radiators in the furthest guest bedrooms take a few minutes to catch up.
That is the exact physiological mechanism at work. Peripheral circulation is the very last thing to fully open up after birth. The newborn's body is naturally prioritizing sending highly oxygenated blood to the brain, the heart, and the lungs.
So the hands and feet can wait.
Exactly.
Which means appearance is the category most likely to produce a perfectly healthy baby who never scores a 10.
Oh, yeah. Generations of nursing students are shocked to learn that a perfect 10 is actually quite unusual. If you were to check your own birth records or, your kids' records, you might see an 8 or a 9.
Most vigorously screaming, incredibly healthy babies score a 9 just because their hands and feet are a little blue for the first couple of minutes.
Right, it's completely normal.
Well, that should relieve a lot of nervous parents reading their charting. So next up is P for pulse, meaning heart rate.
Right. A score of 0 means no heartbeat. 1 point is given if the heart rate is below 100 beats per minute, and 2 points if it is 100 or above. And I really want to emphasize this category because it is the single most heavily weighted piece of clinical information in the entire score.
Because it dictates the immediate response in the room, right? Like, if that heart rate is under 100, you aren't waiting around to finish the rest of the checklist.
Exactly. A low heart rate at 1 minute is the fastest, most reliable trigger for a neonatal resuscitation team to intervene. Long before they evaluate muscle tone or color, if they hear a heart rate dipping into the 80s or 90s, the protocols demand immediate action.
Like clearing the airway and providing positive pressure ventilation?
Yes, immediately.
Okay, moving down the acronym to Grimace, or reflex irritability. I imagine testing reflexes in a newborn is tricky. You can't exactly ask a 1-minute-old baby to follow a pen with their eyes or, like, tap their knee with a hammer. You'd have to rely on raw physical stimulus, right? Like tickling their feet.
Close to tickling, yes, but a bit more robust. Classically, the provider will flick the sole of the baby's foot, or they'll observe their reaction when a suction bulb is placed in their nose or mouth to clear fluids.
And how is that scored?
0 points means no reaction at all. 1 point for a weak grimace or a weak cry. And 2 points for a vigorous cry, a cough, a sneeze, or the baby actively pulling their foot away from the stimulus.
So it gives the team a real-time assessment of how intact and responsive the central nervous system is.
Precisely.
Then we have A for activity, which measures muscle tone. 0 points for a completely limp, flaccid baby, 1 point for some slight flexing of the arms and legs, and 2 points for active, spontaneous movement. Now, why is muscle tone such a critical indicator of oxygen?
Because muscle tone is one of the earliest physiological functions to drop when a baby is short on oxygen. The newborn brain is incredibly efficient and honestly ruthless about survival.
What do you mean?
If it senses hypoxia, a lack of oxygen, it will sacrifice skeletal muscle tone just to preserve the remaining oxygen for the vital organs.
Oh, wow. It just shuts off the power to their arms and legs to keep the main generator running.
That's a perfect way to put it. That's why a floppy baby is a universally recognized red flag in obstetric nursing. It tells you the oxygen reserves are critically depleted.
And finally, the R respiration or breathing effort. 0 for no breathing, 1 point for slow, irregular, or gasping breaths, and 2 points for a strong, regular cry.
Which is that lusty, echoing cry every parent in the delivery room is holding their breath to hear.
Yeah.
That sound represents a massive physiological shift. It is literally the sound of fluid being pushed out of the alveoli in the lungs, air rushing in, and the baby's respiratory system taking over the job that the umbilical cord has been doing for the last 9 months.
Incredible. So you tally those up, 0 to 10. Generally speaking, a 7 to 10 is reassuring. 4 to 6 is moderately abnormal. 0 to 3 means serious, life-threatening distress.
Right.
But, it feels completely counterintuitive that a doctor armed with just a stopwatch in their eyes could outperform modern technology. We live in an era of, Apple Watches, instant blood panels, continuous fetal monitoring. You'd assume a visual checklist from 1952 would have been replaced by high-tech lab equipment decades ago.
You definitely assume that. But the clinical data says otherwise. And this brings us to this foundational study published in the New England Journal of Medicine in 2001 by Dr. Brian Casey and his colleagues.
Oh, this is the one where they tested the old-school APGAR score against a highly invasive, high-tech chemical measurement, right? Umbilical cord blood pH. Let's explain what that blood test actually measures, because it sounds like the ultimate objective gold standard.
Biologically, it is. When a baby is deprived of oxygen during labor, their body switches to anaerobic respiration to survive. That process produces lactic acid as a byproduct.
Okay.
So by drawing blood directly from the umbilical cord right after birth and measuring the pH of the acidity, you get a highly precise chemical snapshot of oxygen deprivation.
So it's literally human observation versus a precise chemical blood analysis.
Exactly. And what Dr. Kissey's team found after examining nearly 152,000 births was just staggering. A 5-minute APGAR score of 3 or less predicted neonatal death in the first 28 days of life, better than the high-tech umbilical cord blood pH test.
Wait, really? How does that even make sense? How does a person just looking at a baby beat a definitive chemical analysis of their blood?
It reveals something really profound about the difference between a static data point and dynamic biology. A lab test gives you a number about the chemistry in the blood at 1 exact millisecond in time.
Right.
But a 60-second visual checklist performed by a trained human being captures a holistic picture of transitional physiology. It captures the heart actually pumping, the brain reacting to stimulus, the lungs expanding, the muscles firing.
It synthesizes the entire organism's struggle to adapt to the outside world.
Exactly. Whereas complex chemistry can sometimes miss that bigger picture of resilience.
The word resilience is key there, especially regarding the timing of the score. Because Dr. APGAR originally intended for this to be checked just once, at exactly 1 minute after birth.
Right. But clinicians quickly realized that the 1-minute score essentially reflects how rough the labor and delivery process was. It acts as a baseline trigger. If the score is low at 1 minute, you start clearing the airway, giving oxygen, or beginning compressions.
But the 5-minute score reflects something entirely different. It reflects how well the baby is responding to the help they are being given.
Yes. And today, the medical guidelines reflect that ongoing assessment. If a baby's 5-minute score is still below a 7, the team doesn't just stop scoring. They will assess the baby again at 10 minutes, 15 minutes, and even out to 20 minutes of life, charting the trajectory of the baby's recovery.
That makes a lot of sense. But because this number is universally recorded on every single birth chart, and because it's so easy for anyone to understand, I mean, it's a simple grade between 0 and 10, it inevitably became a weapon outside the delivery room.
Unfortunately, yes. Specifically, it became a focal point in birth injury and cerebral palsy litigation.
For decades, it was a favorite battleground for plaintiffs' attorneys. You can easily imagine the scenario in a courtroom. A lawyer presents a medical chart to a jury of laypeople and says, look, the baby scored a 2 out of 10. That is a failing grade. This is absolute proof of birth asphyxia.
The hospital negligently deprived this baby of oxygen, and that negligence caused this child's permanent brain damage.
Right. And it's incredibly persuasive. We are all conditioned from kindergarten to view a low score as a failure. But you're trying to use a 1-minute snapshot of a rough transition to predict a 60-year lifespan.
It's completely out of context.
It feels like looking at a basketball team having a terrible first quarter, like maybe they're down by 20 points. If you immediately declare that the coach is legally negligent, the players are terrible, and the franchise is permanently ruined, you're ignoring the rest of the game.
That is exactly it. Meanwhile, there are 100 other reasons they might be playing poorly in that specific quarter. The opposing team is shooting unusually well, your star player has the flu, or it's just a random cold streak.
Yeah.
In the medical context, there are dozens of reasons a baby might have a low APGAR score that have absolutely nothing to do with negligent oxygen deprivation.
Such as maternal sedation crossing the placenta, or, congenital anomalies and underlying infection, or just a difficult but entirely non-negligent delivery process. A low score is a symptom, not a definitive diagnosis of the root cause.
Right, and this legal misuse became so widespread and so damaging to the medical community that in 2015, the two biggest governing bodies in the field, the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics, had to formally issue a joint committee opinion.
Oh, wow. What did they say?
They explicitly stated that the APGAR score alone cannot diagnose asphyxia, and it is a poor predictor of an individual baby's long-term neurological outcome.
They essentially had to draw a line in the sand and demand that the legal system stop using a 60-second observation as a lifelong causal verdict.
Yep.
Which actually leads into another major debate surrounding the score. It's fairness to premature babies. If a baby is born weeks or months early, their biology just isn't equipped to ace this test.
Not at all. Premature babies naturally score low because their physiological systems simply haven't finished forming. For example, their nervous system lacks the myelin coating required to send rapid, robust signals to skeletal muscles, so they appear floppy and score poorly on activity.
Makes sense.
And their peripheral circulation is immensely underdeveloped, so they will almost always lose points on appearance.
So a preterm infant might score a 3 or a 4, not because they are in acute life-threatening distress from a botched delivery, but simply because of their sheer developmental timeline. The original APGAR score didn't have a handicap or an adjustment for prematurity. So how does modern medicine account for that without, artificially inflating the score?
Many modern medical centers have adopted what's called a combined APGAR approach. It is a really elegant solution to the context problem. Alongside the numerical score, the medical team notes exactly what resuscitative measures are being given at that exact moment to achieve that score.
Ah, because a baby who is pink, crying, and vigorously kicking all on their own and scoring a 9 tells a fundamentally different physiological story than a baby who is scoring a 9 only because a medical team is actively giving them CPR, intubating them, and pushing epinephrine.
Exactly. The combined score provides the vital context of what it took to get the baby to that state, which perfectly honors Virginia APGAR's original intention.
Right.
She didn't want a tool for judgment. She wanted a tool for intense, rigorous observation of the reality in the room.
Looking back at this incredible journey, it's just amazing. The APGAR score was born from a marginalized female anesthesiologist's desire to bring discipline and attention to a chaotic environment. It was retrofitted with a catchy acronym by a completely different doctor. It stood its ground against modern high-tech lab chemistry, and it's had to be fiercely defended against legal misuse.
And Virginia APGAR's legacy extends far beyond this single score, too. She went on to become a leading advocate for birth defect prevention, doing this groundbreaking public health work regarding rubella and folic acid supplementation through her later career as a director at the March of Dimes.
She even appeared on a U.S. postage stamp in the 1990s and, had a Google Doodle dedicated to her. That is a rare, spectacular degree of public recognition for a clinical scoring rubric that was supposedly sketched out on a scrap of paper over breakfast.
It really is a testament to the enduring power of a simple, brilliantly effective idea.
It really is. And that leaves us with one final thought to mull over today. We've spent this time focused on the APGAR score, but it actually sits alongside other highly specialized human observational tools you might encounter in medicine.
Right, like the Ballard score.
Yeah, the Ballard score, which estimates a premature baby's gestational age just by looking at physical signs like skin texture and ear cartilage. Or there's the Silverman-Anderson score, which grades respiratory distress based purely on observing chest retractions and nasal flaring. It really makes you wonder, in our modern world, where we are utterly obsessed with artificial intelligence, complex predictive algorithms, continuous digital monitoring, and chemical blood labs, what other complex, seemingly unsolvable problems in our daily lives might be solved if we just stopped relying on our technology, stepped back, and created a simple 5-point, 60-second checklist of human observation?
That is a very powerful question to walk away with. Sometimes the most sophisticated and reliable diagnostic tool in the room is simply a trained human being paying very close attention.
The very first test you ever took didn't require a microchip, a battery, or an algorithm. It just required 60 seconds and someone who cared enough to really look at you. Thanks for joining us on this deep dive, and we'll catch you next time.